you think everything is done by ERCP, but we are happy now that people or our patients are surviving longer, so they can experience also problems in the future. And I'm very happy to give the speech to Schalk van der Merwen, who is already there with his team ready to show us how to go on if there are problems you cannot solve by ERCP anymore. Schalk.
Thank you, Marcus. If I can introduce my team, Dr. van Malenstein, Dr. Braunzweig, our colleagues working here at the University Hospital in Leuven, and our excellent team, support team, our nursing team with Eva and Philippe in the room. And we also have our patient being intubated and ventilated with our anesthesiologist present. So this case, I'm not sure if you can see the case being projected on the screen. We are having to deal with a patient that has an inoperable cholangiocarcinoma. The patient was stented before in 2021 in July. He then received an uncovered metal stent. The patient received chemotherapy with cisplatinum and gemcitabine with an objective tumor response. He subsequently developed a cholecystitis, which was also drained by an axios placement, and the patient has been well for the last year, but now returns with increase of the cholestatic liver enzymes and bouts of cholangitis that were treated by antibiotic therapy. And on the imaging, you should see that the bile ducts are dilated, especially the left system, so that we would, in this case, aim to perform a hepatogastrostomy with the intention of draining the left system away from the hilum. And in so doing, we would expect the stent to be patent for longer. And in this patient with an obvious tumor response and slow growth, it will be important to maintain patency as long as we can. So we're now in the stomach, in the proximal stomach, and you should be able to see that the needle, the sheath of needle is coming from the right. You should be able to see that the ducts are mildly dilated. We've measured the duct, it's about 3 millimeters, and we should now be able to proceed with placement of the wire under EUS control. And if the wire is in place in the duct, we will fill to confirm our position for the duct with contrast and then advance the wire. So we'll take you through these steps one by one. So at the moment, you can see, if you can just hold it like me for that, in that position, you can see that there's a blood vessel to the left and a small intrahepatic dilated bile duct to the right. We will now very carefully advance the needle, try to avoid the blood vessel altogether whilst advancing the needle under EUS guidance into the dilated bile duct. And we want to be sure that we can see this well. So there you can see we're now entering the bile duct.
So we're in segment 2?
We're in segment 2, because in segment 2, we normally have a good position as it follows normal curvature of the bile duct. So I want to focus on the hands of Eva now. Eva will now aspirate. And this is extra confirmation. You sometimes see bile coming back, as you can see there. And sometimes you just see the column of contrast coming back, which is already indicative that you're in a good position. So Eva will now inject very carefully some contrast so that we can define the anatomy, avoiding over-injection. I think that is already a very good, that's already enough. Eva will confirm this by taking an image, and you can clearly see now the left side is dilated. It is not an atrophic segment, so it's worth draining. You can see that there's almost complete obstruction. And now Eva will remove the tubing, and she will insert through the needle a guide wire. We used a basic light guide wire 0.025, and we've just used a hook. So if we can increase the size of our, so the reason why, Marcus, it's a monofilament wire, it doesn't shear easily, and it helps us to maneuver the wire. So with the wire now in place, we will carefully remove 90 gauge needle altogether. Eva will keep the wire in place. And we will remove the wire, we will remove the needle while maintaining the position of the wire very carefully. And I think the next steps will be crucial, because in the next step, we will use a 6 French cystotome to create a tract between the stomach and the dilated left system, so that when we advance the stent, that the stent can be easily advanced into the biliary system. So we've removed the 19 gauge needle. What do you think, Hannah? Is that the position adequate for you?
Yeah, sure. It's segment 2, so we already confirmed beforehand that we are in the stomach, because sometimes it's really high, and you have to be sure you're not too close to the esophagus, to the gastroesophageal junction.
I think that's a very good point, is that you want to place the stent not through the esophagus, as Anna rightly says, but in the stomach. So in preparation, we would make sure that the endoscope is deep enough. That's a very good point, Anna. I didn't mention it.
There is a question from the chat, Schalk. Do you use a straight tip or angle tip guide wire?
We use a straight tip, and the reason is that there are actually 2 reasons. The first is that it's not really necessary to use a curved tip, and the second is it can sometimes be quite difficult to get a curved tip through the 19 gauge needle. For some other reason, our nurses really battle sometimes to get it through, and only in settings where you really need to traverse a difficult stricture will we switch. So now we will advance the cystotome. Okay. And I think the next step is very crucial. In the next step, when we create the fistulous tract, I want you to note 2 things. The first thing that I will point out is where the stomach is, because that will be a reference where our stent that we will place needs to end. It needs to end beyond that point. So as we advance the cystotome, you can see I'm now against the stomach wall, and that is at the edge of the vertebra. So I know that at the edge of the vertebra, there the stomach lining is, and our stent needs to finish beyond that in the stomach lumen. The second point that we will focus on is as we insert the cystotome, we will enter into the bile duct, and that is where the uncovered and the covered part of the stent should meet. So we will, as soon as I feel the loss of resistance, I will then take a thorough image, and that will be my reference image that we will put on the left side of the screen. And we know then that that is a place where the bile duct and the hepatic parenchyma then meets, and we need to deploy our stent such that the uncovered part is at that point.
And so maybe also in addition, when you puncture the first time with your EUS, that your bile duct is not too close to the stomach wall, that you have some distance to.
Absolutely. I think that's also a very good point that Anna makes, is that you want at least some parenchyma so that the dilated duct is not just beneath the capsule of the liver, because then it may tend to leak after placement.
You can shortly see the EUS image just to see that there's some distance, as you already showed before.
So now we will advance the cystotome. It's already connected. We have it on endocut 2, and we will now advance the cystotome carefully through the hepatic parenchyma. You can see there it moves. And at that spot there, I feel loss of resistance. So I know there is the transition, and I will take the image that we will save as a reference from where the transition between bile duct and parenchyma is. So now I can advance the cystatome into the bile duct. It's not the purpose of this examination to try to cross into the stent, because the decision is made to drain away from the hilum in order to keep this patient from cholangitis and stent dysfunction in the future. So that is already a good position. So now I will come back with the cystotome. It served its purpose. If I will again advance the guide wire to keep us in good position. And now we'll come back. And we will, for this purpose, we'll use the gearball stent, the stent developed by Mark Giovannini, that has approximately a 3 centimeter uncovered part, and the rest of the stent is covered. We'll use the 8 centimeter, the 80 millimeter by 10 millimeter gearball stent.
During exchange, may I ask a question? For the cystotome, you use a very small diameter, so 5 French or 6 French?
Yeah, I think that's a very important question, because we want to use a small diameter. Should we fail, then the track will simply collapse and we will not end up causing a perforation. So a 6 French stent is absolutely perfect for a 6 French diameter cystotome is actually perfect for that indication. It allows us to create a tract, but it also allows us, should anything happen, that the patient will not develop signs of perforation, because the tract will simply collapse on itself.
Are there situations where you use a blunt opening of the stomach and the liver by a dilatator or something like that?
I never do that. I think that, that, in my opinion, is very seldom necessary. And also then you actually, the benefit that you had by using a, let me just advance the stent, there we're in, the benefit that you had by using a 6 French cystotome, you actually don't have then if you dilate, because you'll create a tract that is larger, and that may lead to a high risk of pneumoperitoneum. So we're going to just increase the image size, and then I'm going to take you. So on the left-hand image, we made sure that we recorded the site where the transition occurred between the bile duct and the liver parenchyma. And what is going to be very, very important now is that Eva will deploy the stent, and I'm going to ask her to stop as soon as she reaches that marker that is at the level of the transition. So maybe Hannah, you can show where that marker is. Point that out. So that's the marker in the middle of the screen at the level of the pedicle of the vertebra. There is a radiopath marker, and then you see more distally in the bile duct the stent, and Eva will now deploy. And as she deploys, I will gently pull back, make sure that the stent remains in position as we would normally do. So Eva can gently deploy, and Eva knows that if she reaches that point, that she will wait. Okay, that's perfect. So, yep. Okay. So we're now at the point where the transition is, and when this occurs, I will then gently pull back the endoscope to make sure that I keep traction on the stent, so to prevent the stent from migrating inwards and the stent opening up in the peritoneum rather than into the stomach lumen. So we really do not trust the endoscopic view at this point, as this can sometimes be confusing. So we focus only on the fluoroscopic image. So if I will now start to deploy further, I will gently pull back, make sure that there's tension, that we will always end up with a stent in the stomach. So I'll gently pull back, and if I can continue to deploy. And now at this point, I am pretty sure that the stent should be in the stomach, visible. And in the final steps, we can deploy the stent. You can see that the stent now in the stomach. And then you see the endoscopic view clearly now. Yep. So if I can now withdraw, so I'll pull back the stent while the guide wire remains in place. So we now pull back the button, and as you can see, the stent is placed. We still have the guide wire in position. So should anything have happened, we have the guide wire to protect us, and we can still utilize the guide wire. But in this case, it's not necessary. So there one can see, I don't know if the endoscopic view is visible, Marcus. There one can see the stent deployed in the stomach. Is it visible, the endoscopic view?
Yes.
Perfect. Okay, so we can be sure that the stent is well positioned, that the stent opens up in the stomach, that there's at least 2 or 3 centimeters of the stent in the stomach. And I think that this is a very valuable procedure, as it now drains away from the hilum. And because the stent is uncovered in the bile duct, side branches can also drain. And this should mean that this patient should stay free of cholangitis for prolonged periods of time.
Well, Jacques, this was a brilliant presentation, and it's when we watch you, we could think it's very, very easy, but I guess you pointed out a lot of crucial points during the procedure. May I ask you a question? Because Alberto mentioned we need more specific EOS tools to do the drainages. And when we look at the lamps, we are used to connect the stents very straight to the echo endoscope. Could you imagine for the hepaticogastrostomy some similar tool where we have really this very, very smooth deployment mechanism, and we know at every stage of the procedure where we are, where the stent is, we deploy it into the scope and then advance it outside?
Absolutely. I think that this technique needs further simplification and standardization, Marcus. And I think that we have been speaking to the companies now for many years. I think at least some of the steps can be simplified, especially if you can have a device where you can insert the needle, you can advance the wire and perform the incorporate it into that device, have a cystotome so that you don't have that exchange at least. I think that will already simplify this technique tremendously. And then I think the gearball stent is a great advance because of the fact that it's uncovered. But you need to have some experience with placement. It's something that can go wrong. You can end up placing the stent if you're not very careful in the peritoneum. If you just push the stent out while the nurse deploys, the stomach will just simply be pushed away. So I agree with you. We need to simplify this so that for the next generation that people can be more comfortable if we want this technique to be more accepted and utilized outside academic centers and people with experience. So yes, absolutely.
Skalk, we need to move. Nice procedure. Thanks to Marcus for the discussion from the friendship. So we'll have a 1 minute, 2 minutes rest, and then I will present the next case. Thank you.
Thank you, Marcus. Bye.
Thank you, Jacques. Thank you for the invitation. Bye, Alberto.
Bye, Marcus. Hello, we're back. So we saw the advertisement from Taiwan. We'll continue with the Taiwan product, different RFA, and who can be the best demonstrator of RFA procedure than Bertrand Napoleon from Lyon, who will be moderated by Ari Benson from Jerusalem, Israel, with whom we are working as part of a study on RFA for neuroendocrine tumor. So Ari, I'll give you the word and introduce the procedure, please.
Thank you very much, Alberto and Schalk, for organizing this fantastic global EOS event. It's really great to see all these procedures performed live. And let's just get right to the procedure. So I'd like to introduce Dr. Bertrand Napoleon, who's going to be performing a EOS-guided RFA of a neuroendocrine tumor. Please.
Okay, good morning, everyone. Thanks, Alberto and Ariel. So you see the material, so I will not come more on this. We will see the case. You see it's a female, a young female, with a hypoglycemia crisis since 5 years. The fasting test was positive. CT MRI didn't evidence any tumor, but EOS showed a 10 mm large lesion of the upper part of the pancreatic head, 2 millimeters from the Versum duct. They did a puncture, which confirmed that it was a G1N. PET was positive and PET FDG negative. So the scheduled procedure is EOS-guided RFA. So we can go further directly on the EOS screen, please. So I discovered the cases with you. So you see that we're on the body on the pancreas. If I put the flow, you see very easily where is the pancreatic duct here. It's not dilated. And if I go back to the upper part of the head, you see that we clearly see a lesion, which is a bit hypoechoic with irregular shape. If we measure it, it is 13 to around 9 frequent. It's not very round shape. It can be a bit oval. And of course, it is the insulinoma. So when you decide to use the RFA to destroy it, you have 2 important things to check before. The first one, of course, is the proximity with the pancreatic duct, because it's the only factor that is clearly enhancing the risk of adverse events. If you are very close to the pancreatic duct, you can burn it and then have the risk of secondary fistula, for example, or of acute pancreatitis, which is a risk around 10%. So you see that if we check, the lesion is very well vascularized, which is classic for a neuroendocrine neoplasm. And if we follow now the pancreatic duct, I will show it here. You see that in some parts it's far, at least 2 millimeters to the tumor, but in some areas it's very close. Here probably it's less than 1 millimeter. So that's one problem. The second question is, are we far from the outer part of the pancreas? Because here can be also a problem. One of the rare problems you can have after destruction of the lesion is a fistula. Because if all these tumors become necrotic, it's not rare that there is a connection with a slight collateral of the pancreatic duct. And if you have also induced destruction of this part and of the mucosa, you can have a fistula and secondary cirrhosis. So that's, I think, the 2 main risks. So here we can say that we are not so far from the periphery. If we check the lesion, you see we are very close to the wall and very close to the pancreatic duct. So that's a discussion we have frequently. Here we could say, okay, it's too close to the pancreatic duct to choose the RFA. We must go on to surgery. We can also have other solutions. One should be to say we put a prophylactic plastic stent. It can be discussable. It's not so evident because you have also the risk to insert the stent. And here, in the specific case of the insulinoma, you can also say, okay, the main purpose is to stop the secretion. So we are not necessarily wanting to have a complete destruction of the tumor. So we could imagine that even if we have a very thin band of active tumor who remain close to the pancreatic duct, you will be certainly efficient on the secretory syndrome. So we discussed that previously for the lady, the balance and advantages of the surgery. And finally, we decided to maintain the indication of RFA and with the idea to try to preserve this very small area between the tumor and the pancreatic duct. Due to that, I prefer to use a needle with an active tip of 7 millimeter long. You know that we have the choice, 5, 7, 10. Usually it's 10 who is the most frequently used. But here I prefer to use a 7 millimeter long tip because I will be probably a bit more precise to destroy exactly where I want. Considering the power, we choose 50 watts. We want to have a necrosis, of course, and to reduce, if possible, the burning outside of the necrosis. So if you want that, you have interest to use a high power and not a low power. After, there is an important point. Certainly, if you imagine that it is a volume, with only one pass, I will not be able to really destroy completely the lesion. So I prefer to plan, in this case, to have 2 passes at least. The first one, in this case, you always must choose the more difficult because after the first irradiation, you will have a lot of bubbles inside the lesion and it will be more difficult to be very precise on the second pass. So my first pass would want to go around there, not too close to the pancreatic duct, to try to destroy, I would say, this portion of the tumor. And after, if needed, I will do a second pass on this side. So
are you using prophylactic NSAIDs or
yes, absolutely. You're completely true. We do systematically antibiotic prophylaxis and also insertion of non-steroidal suppository. We hope like that, reducing the risk of infection and of acute pancreatitis, even if it's difficult to really prove the interest. So I think you have seen the arrival of the catheter. The needle is very, very nice, I would say, because the penetration is very good. And the tip is also very easy to follow. So we will try now to go inside the lesion. You see the tip of the lesion. So perhaps I'm a bit too close, to the pancreatic duct. If I push a bit more, yes, I would prefer to be here. Okay, so as frequently with the 19 gauge, you need to push firmly, I would say, to be sure that you are really inside. And then you remove gently the needle to be sure about the tip. You see the tip now, it's clearly seen. It is here. Sorry, it is here. So we will, if you have any doubt, you can move it a bit, okay? Pancreatic duct is here, okay? I think you see that. You can have, okay? So we are not so close. You see, we are at around 4 millimeter, 3 millimeter for the pancreatic duct. So I hope that in this situation, we will not have a burning of the pancreatic duct itself. So the position is good. The tip is here. So I will do the first irradiation. So I press on the pedal. Okay, and now I'm checking the arrival of the bubbles. You see that progressively some bubbles are coming inside. And we had also a drop of impedance. So you see all these bubbles, which were around the needle. And the drop of impedance say you that you have no more lesion around the needle. Necrosis is obtained. So you must stop for the first pass. So now we will change of area. If you look to the tumor, you see that part of the lesion is now hyperechoic. You see also that we have no bubbles close to the pancreatic duct, so we can hope that we respected it. But you can also very easily see that there is a large part of the lesion which is always alive. So we will now check another area.
Do you ever use fine flow or possibly contrast to help guide the location of the application?
Yes, you're right. We do that, but more after the session. After we are sure that when we imagine that in B mode we have no more active tissue, then we do a contrast to see if there is or not part of the tumor which is always vascularized. But here in B mode, already you know that you have not been completely efficient. So I will do a second pass here. You see the tip of my needle, which is well seen here. So we'll do a second irradiation. So you see the bubble arriving. And another drop in impedance. So 2 drops. If there is not a drop, which sometimes arrives, you must stop when the bubbles are very close to this part of the needle. So we will check now if we have other parts. You see here clearly that we have this part that has not been treated. You must consider and remember that it's a sphere. So in 2D and 3D, it's really different. You could say, okay, I did everything, but if you turn your scope, you see that clearly not. You have all this area which is not treated. So I will move a bit my scope, and we will try to now treat this part. You see that we are not so bad. The tip of the needle seems well to be here, but I'm not so sure, so I will remove the needle, and you see that, in fact, it is here. So that's very important. When you push frequently, you go further, which is not a problem, but you must be sure then that the tip of your needle is really here. So here I convince that it's well positioned, and I can do a third irradiation. So always keep your foot on the paddle, because if you find that it's enough, I will remove a bit. Ça tourne toujours là? Okay. You can also do that. You remember that I choose only a 7 millimeter long needle. So you can begin, if you have, for example, 12 millimeter to destroy, you can begin at the deeper part and then remove a bit your needle to continue to the more superficial part. So what is the result now in B mode? Honestly, I think it's better. Perhaps the last shot here could be done. Usually we do between 3 and 4 shots. In fact, it depends really on how is the appearance of the restriction. Okay, I will do a last shot here. And after we will do some confocal to check, if there is always or not some vascularized tissue. So
there's some questions from the audience.
Yes,
I think you had mentioned this at the beginning of the procedure, but they're also asking again how you chose the size of the RFA catheter, and if possible, a smaller size might be better because of the proximity to the pancreatic duct.
Initially, I always choose the 10 millimeter because we were used to it and so on. But in some cases, especially in insulinoma, that are small lesions that can be far from the probe, the advantage to use a shorter needle is that probably you have a needle which is easier to insert. And I have, in my experience, 2 cases where I was unable to reach the lesion with the 10 millimeter and I succeeded with the 5 millimeter. So if really the lesion is bigger, I would say around 50 millimeter large, round shape, I would clearly choose a 10 millimeter large long needle. And I choose 7 or 5 only where the lesion is smaller and that I want to have a very precise treatment.
There's another interesting question from the audience. If you would ever consider injection of glucose into the lesion prior to RFA, as it might augment charring.
Excuse me?
It's an interesting question. That would injection of glucose help augment the effect of the RFA?
Oh, I don't know. Never tried that.
I don't know either.
Okay. So if you agree, we will now check the lesion with confocal mode. So as Masat showed you, the lesion is here on B mode. You see? Okay. So it's here on contrast mode. So we will inject. Cecile will inject. Oh, I forgot to present my team. I'm sorry for them. My 2 nurses, Cecile and Hélène. Richard, our anesthesiologist, and Tofik, a fellow from Israel. So you see the lesion. You remember that it was very vascularized initially. And I think that if you compare the image in B mode, it's the lesion, and you clearly see that it's now a black hole. If you compare the 2 areas, you see, for example, here we should think it was also the lesion, but it's now black. So if we now check the whole lesion, if we compare B mode and contrast mode, honestly, I think that I will stop my procedure here. You also remember that in the prospective trial that has been conducted by Parte in France, some lesions were destroyed also after some months. So the destruction is continuing after the session. So for this session, I will stop here, and I will now see if the patient has a normalization of hyperglycemia.
And are you monitoring the patient during hospitalization in a hospital admission, or can you consider doing this ambulatory?
What we do usually is to have the patient during one night after the session in order to be sure that he's not, we didn't induce an acute pancreatitis. In the very large majority of cases, there is no problem on the first day. But we must also know that the adverse events can arrive later. So in the French prospective trial that we will publish soon, almost half of the complications arrive after 2 or 3 days, especially the complications that are induced by a fistula from the pancreatic duct.
And what's your follow-up imaging for these types of patients?
So
US at a scheduled interval or other imaging?
I systematically see the patient with a CT 2 weeks after the RFA to check about long-term complications. And after, it depends on the case. For insulinoma, it's very easy because the problem of the symptoms, and the patients know very well if they are cured or not. And they know also what are the symptoms if there is a recurrence. So finally, in insulinoma, we do a very few follow-up with morphological exams. With a non-functional net, we follow them. And that's a very good question with CT or MRI, AOS with Sonoview. And I think also that for the longer follow-up, DOTATOC is necessary.
Great. This is a fantastic demonstration of RFA. It's like many US procedures, very gratifying, particularly in young patients when their symptoms disappear within a very short while. So thank you very much.
Okay.
Absolutely. Thank you very much, Bertrand, for that beautiful illustration, and for Ari for moderating the session for us.
The endorotor is an interventional resection device to be used during endoscopic procedures by a trained gastroenterologist or interventional pulmonologist. The endorotor has several cleared indications for use. Consult instructions for use on endorotor contraindications. The endorotor endosurgery system consists of a console, foot control, vacuum pump, and catheter. Ensure the correct catheter length is selected for the appropriate scope. The catheter requires a 3.2 millimeter endoscope working channel. If you have additional questions on the catheter selection, please consult the endorotor instructions for use endoscope compatibility chart. Ask the physician if the procedure is a powered endoscopic resection, tissue collection, or powered endoscopic debridement, no tissue collection, and select the corresponding in-service video. The PED catheter has a serrated tip, comes in various lengths, and allows for purging of debris. All catheters require a 3.2 millimeter endoscope working channel. The endorotor PED catheter is available in the following configurations. Disposables required for the procedures where tissue collection is not desired are endorotor purge kit, 20 milliliter syringe, a bag of normal saline, 250 milliliters to 1,000 milliliters, suction tubing,
No, because we don't hear
and suction
anything
liner for the
in the
independent
rotation,
ER
there's no
vacuum.
sound. We can hear that.
So we should present the case. So Gianenrico, please present the case.
This is the case of a 75-year-old female.
Gianenrico, please.
She has HCV-related chronic liver disease and previous breast cancer. Due to weight loss, abdominal pain, and nausea, she underwent abdominal CT scan, which demonstrated a 4-centimeter pancreatic lesion with bile duct dilatation and lung micrometastasis. She failed primary biliary drainage with ERCP. Scheduled procedure is EOS guided FMB of pancreatic mass and choledochondrostomy. Please, Alberto.
Let's go.
I'm here.
You're there. Okay. Sorry. I didn't see you. US view, please. Okay. So this is the mass. So this is a patient unresectable, and if you do examination, he has also ascites here. So there's no meaning to do a full staging procedure on her. And so in this case, we needed to do a tissue diagnosis and then to do some consideration about how to drain these patients. So and FMB now, I think, are the way to go. If you have a cytotechnician or a cytopathology, you can do touch and bring cytology. That is actually better than ROSE. And if you think about, I think now FNA needle have a really small space left, at least for regarding tissue diagnosis and especially tissue molecular characterization. Because if you look at companies that do perform NGS, they do perform on tissue samples and not on cytology. So the way to go now is really FMB. So we will have two FMB needles. Which we will perform the procedure. The first one is the microtech needle. And what characterizes an FMB needle as compared to an FNA needle is the tip. So the microtech needle has a multi-blade tip with a three-pronged tip to facilitate acquisition of tissue for histological samples. So we are working with the new Fujiscope, the prototype EG740 UT, and with the US Fuji processor, the US1. They will announce something new in UGW. I wanted to announce today, but I didn't say no. So there's going to be a big changes in their system. And the scope is basically as a new transducer that allows for a better ultrasonographic sensibility and a better visibility deep. There is also they adapted as a Pentax working channel of 4.0 millimeter, and they have also a guide wire system to block the guide wire similar to ERCP. And as compared to the other one, I don't know because I didn't try before. There is a better ergonomics, so it's much easier to handle. So we go to. With the first needle, I use the wet technique. So I take out the stylet, I fill up the channel of the needle with saline, and we put everything directly in formalin.
So I presume you are in the general bar.
I don't hear anything. Sorry?
Can you hear Alberto?
Yeah, now better.
So just to inform the audience, I presume you are in the general bar.
Sorry? What happened? Something wrong. Sorry, but there is something wrong with the needle? I don't know. So can you give me another one? Or the Procore? Whatever you want. So the Cook, the Procore 20. We actually did the first studies, the multi-center study with Marco Bruno. And the Procore 20 also has a tip, which is a Mengini bevel tip to obtain samples, and has a core trap technology that has been designed to receive samples into the needle. Okay, so now the needle is out. We can see the patient is already on antibiotics, so we really did not need to give her antibiotics. 1. So visibility of the needle. 1. Sending. 2. 3. So this is the way I do, because I think if you think about biopsy, transcutaneous biopsy, you do one shot. So I don't want to pass through the same region more and more, so your sample becomes very bloody. So this is a very easy way to do it because everything is placed in formalin. And the specimen, we actually did a multi-center study to reviewing the samples from various team who participated to the study from with the Procore 20, and our sample were the best, and were actually the one who were treated easily. So just put everything in formalin. Another needle from Microtech. I don't know what happened before. Sorry, Lasco, I don't hear you very well. Can we try? You want to talk?
Can you hear right now?
Now I heard you, but just a little bit. Jenny. This needle should go for all the scopes. I don't know what's happening. Okay. Okay, so I go back to the duodenum. Any question? Any doubts? Any?
Can you hear Alberto?
Yes.
So you mentioned that you were using the wet technique. So what is the benefit of this wet technique as compared to the vacuum technique?
Which technique?
Wet. You mentioned you use the wet technique.
The wet technique. So we actually just finished and published a study where we compare, in a multi-center study, we compare the wet versus the pull-up technique. And basically we found that for both, so this is very visible, sorry, the needle. This is from Microtech. So I will try to, okay, so there's 3 passes and for me it's done. So the wet technique in our hands in this multi-center trial that has been published in endoscopy, we found that is superior in getting tissue and reaching a definitive diagnosis than the pull-up technique. So I've been using basically the wet technique since 2008 because I started doing FMB in 2008. Not because I wake up with a very nice idea, but because in my place, the cytologist was a great cytologist, but for the thyroid, and he never get interested in the pancreas. So we had a lot of, we had a low yield. So I decided to use the 19-gauge needle for many indications to get tissue instead of FNA, and this is work. So then, companies started developing FMB needles, and so we are now we are in the FMB era.
Alberto, can you show us the sample you obtained?
Can you show the sample that we got it? One sec. Chiudo perché sì. Aspetta, se no faglielo vedere aperto. It's too far away. It's too far away. You should bring it close to the camera.
Yeah, we can see it. It's a little bit blurrish, but we can see the material, yeah.
Yeah, but indeed, the slow pull technique, with the slow pull technique, there was less blood, but at the expense of less a decrease in accuracy. And to me, blood in a histological specimen doesn't make a difference, while in cytological specimen, can create artifact and difficulty in the analysis of the samples. So now we're going to look at the way to perform drainage. So this is the bile duct. Bile duct. So the bile duct is around 40 millimeters, and you can see here the attachment of the cystic duct. Show it. The cystic duct, and you can follow. And it goes to see the big, huge gallbladder.
Yeah, nicely done.
So there are 2 ways of draining these patients. One is a choledochole duodenostomy. The CBD is not huge; it's 14 millimeters. So usually the 12 millimeters is for expert, the 15 to non-expert. And if you find, we perform a study on almost 300 patients that arrive with a lesion in the distal bile duct, malignant, and we measure the bile duct at the level of where you will perform the choledochole duodenostomy. And basically, 12 millimeter was present in 79% of the cases, while 15 was presented in 51% of the cases. That means that the possibility to perform choledochole duodenostomy by many people is precluded by the size of the CBD. Another way to drain these patients would be to drain from the gallbladder, because he has a huge, massive gallbladder. It's less risky than the CBD, but we'll see. And if you think about, there are 2 studies about gallbladder drainage in a patient with a distal malignant obstruction. One is from Japan, with a retrospective, and another one is from the United States, still a retrospective. And the success is pretty high, 90%, even though the follow-up was not so long. So I think I will go for the choledochole duodenostomy. Okay, so I will put the axial stent 6/8. So it's prepared. It's wet, so it's hydrophilic. So in this case, I think you have to do.
Alberto,
yes.
Do you consider in this case a rendezvous technique?
I don't do rendezvous. I don't work in the ERCP, and in this case, this is a malignant. Is a malignant disease. No. It's a malignant disease. She has metastasis. She has fluids in the belly. So she will probably. Okay. She will probably have a short lifespan. So I think choledochole duodenostomy, we are part of a study conducted by Theo, where actually where US ERCP reached the same outcome, but there was a there was a less adverse events and a shorter time for the procedure. So we are working with the RB Bio3 generator. Okay, right. Unclot. So now I will do the opening little by little. Okay. It doesn't work. I'm trying to open the stents.
Could you show us the image?
Sorry?
Okay, it's okay. All right.
So you see we are in. Now we're going to pass to the vision.
Can we have the EUS?
So, no, I can't hear anything, sorry. So that we will do it as usual. It's very hard to. I found very difficult to release each part of the stand. Sorry, one sec. I don't know what's going on, but the stand is very, very, very hard. So it's here, okay. But there was some problems in performing and releasing various.
That's very nice.
1 second that I take out the. I'm not. There's something wrong with the stand because basically I'm not even able to take out the stand from the. No. So it's basically it's against I don't know what's going on, but it's against it got. I cannot take it out from the working channel. So I will take out the scope and put a gastroscope. There's something you see that I had difficulty in putting in the stand and putting out. I don't know if it's because I'm not used to this elevator, even though I didn't use the elevator because my teacher Tom DeSimio, the first things that he taught me was don't touch the elevator, never, ever, ever, because then the stands get stuck and get. But so I hope so they were fast. I think I don't know what they did with the Luce. Huh? So let's see. So this is the technique of opening the stand little by little, and as you can and this is how I teach now access to everybody because you know once you're finding a 10 centimeter here we are. So pus coming out. This is white fever. I don't know what they did on her with the ERCP, and we are fine. Any question?
Alberto, what is the smallest diameter of the CBD in which you perform this collaborative?
So let's say the cutoff is 12 millimeter, but then you can go down to smaller. But I think you have to really be trained to do this way to open up little by little. I really had difficulties during all the procedure because I don't know something got stuck somewhere, so I couldn't really do this very very easily. But to me, pancreatic fluid collection is very easy. No, you have a 10 centimeter balloon and it's easy. Then when you start when your target becomes smaller, 2 centimeter, 1 centimeter, not only the bile duct but the gallbladder, for example. If you want to put a 50 millimeter stent in a 3 centimeter gallbladder or a 2.5 centimeter gallbladder, you need to play around in a certain way. And this is what I started doing. So anything I try to do in a step way, and especially for the people who start, so then they become able to do whatever they want.
There is further questions from the audience. So we could see that you didn't use guide wire. Do you recommend to place plastic pigtail stand inside the Axios?
Pigtail stands inside the Axios.
Yeah, do you recommend it?
No.
Okay, yeah.
So because there's studies, there are studies from Spain that they don't recommend it. There's no advantage in placing a double pigtail stance through the lamps. You might place in case you have something you think that the procedure is something that got wrong or you don't know exactly, and then you can do as to secure the procedure. But otherwise, it doesn't really affect the outcome. And then initially, so these are 6/8. So the diameter is 6 millimeter. So when you place it's smaller than 6 millimeter. So you should it's difficult to place a small stent. You have to dilate, but I would not do it on the first of the first procedure unless something goes wrong.
And there is one more question related to the elevator use, as you mentioned, and I fully agree with you that if you forcefully use the elevator, you might damage the metal stand you are using to apply to insert into the bile duct.